Welcome to the GENMF Primary Care Leadership Program Colloquium on the Coordination of Care at Community Health Centers. This topic will be moderated by Dr. Doug Campos-Outcolt of the University of Arizona College of Medicine's Department of Family, Community, and Preventive Medicine.
Welcome to the Primary Care Leadership Program Colloquium on Coordination of Care. This is part of the GE National Medical Fellowship's Primary Care Leadership Program and the projects that the scholars carried out in the summer of 2013. And we're going to describe each of the projects and the students who completed the projects. I'll then synthesize what I think the projects demonstrated and some of the themes that were common to the projects, and then I'll pose some discussion questions to consider that the projects raise and have application to the healthcare system at large.
Now we'll hear from our PCLP scholars who will each discuss their projects.
Hello, my name is Colloquium, and I attend the University of Texas School of Medicine at San Antonio. I am currently a fourth-year medical student graduating in the spring of 2014. This summer, I had the honor of participating in and completing my Primary Care Leadership Program 2013 experience in San Antonio, Texas. My site was at the Central Med Walsham Clinic on the northeast side of San Antonio, a community health center geared towards those of primary care needs. During this time, I got to shadow and manage patients in the areas of family medicine, pediatrics, and internal medicine. My independent project focuses on factors affecting pediatric coordination of care and specialty referral completion. Coordination of care is a very important concept of primary care because it serves to integrate all of a patient's health care needs within the primary care setting and between other health care facilities and subspecialties. I noticed that for most encounters that required referrals at the site that I was placed, the physician and their administrative team did most of the calling and faxing. This took a lot of time away from clinical duties and the responsibilities that the physician had towards their patients. Thus, I wanted to identify the frequency of pediatric referrals, the effectiveness of the process, and the completion rates by caregivers in order to improve the coordination of care among primary providers and specialists. The methods used in this project included surveys that were given both to physicians and patient caregivers for a period of 4 weeks at follow-up visits that involved referrals. This survey contained questions such as if the patient's caregiver completed the referral, why or why not, what kind of referral was made, and whether the specialist sent feedback of completion to the referring physician. Some of the key findings showed that of all the follow-up visits during these 4 weeks, about 30% involved referrals. 56% of these referrals were made for a second opinion. About 44% of those involved behavioral health, such as autism. Overall, about 78% of patients completed their referrals. The 22% who did not complete their referrals did not do so because of the electronic medical record not sending patient information to the specialist. Thus, recommendations for future use involves an electronic medical record with better capabilities of updating providers when an appointment is completed or canceled, as this could help assist with referral awareness and care coordination. In addition, hiring a coordination care specialist could also help decrease the demand and workload of the physician. Central Med currently has a pediatric care coordinator that helps with organizing and scheduling referrals so that physicians can spend more time out in the clinic and less time figuring out ways to refer their patients successfully. In addition, engaging patients in appointment scheduling could also help with increasing the rates of referral completion. If patients are given the opportunity to provide times that better work with their schedule, then they will most likely be able to complete their referrals and complete their quality of care during their next follow-up visit with their primary care physician. As I reflect back on this experience, I'm amazed at how much coordination of care depends on the interactions of the primary care physician, the patient, and the specialty care clinics. Hopefully, with the recommendations and the duties of a care coordinator, communication between physicians can help put the health of the patient first, as integrating all of their healthcare needs into one visit can be effectively done.
Hello, my name is Kelsey Finn. I attended the University of Utah's Physician Assistant Program. I am a recent graduate, just graduated in August 2013, and will be starting a job in a community health center in California very soon. My placement for the PCLP program was in Jackson, Mississippi. And then my executive summary slide, I did a project on chronic pain policies. My objective was to revise and implement chronic pain policies that follow the most up-to-date recommendations and guidelines while being applicable to a community health center's practice. The methods that I used, so the previous scholar from the year before, the PCLP scholar Christy Goodman, had created guidelines following evidence-based medicine practices, but they had not been put into place by the clinic. So what I did was took the guidelines and did patient care with the chronic pain patients following the guidelines that she had recommended, and then revised them, saw what worked, what needed to be adjusted and fixed, and then also helped to create some tools in the clinic's electronic medical record that would help do better practices for chronic pain. So the key findings that I found were almost all the patients were not having their mental health addressed, which most guidelines do recommend that mental health be treated first prior to starting chronic pain medications. And this was not being done at the clinic. So along with also the documenting was very difficult in their electronic medical record. So what I did was helped make a new template in their electronic medical record. This involved doing evidence-based medicine assessment tools for depression and anxiety, and also for screenings for possible opioid abuse if those were to be prescribed, which was called a SOAP assessment tool. So I was able to input those into their EMR, making it easier for them to track and assess mental health, and then also to be able to make medications, prescribe medications for mental health after that. And then recommendations from doing this project, a new PCLP scholar could review the charts now, see if these assessment tools are being used, and subsequently, if they're using the assessment tools, are they providing proper medications for the results that they're finding. So if they are finding that their depression screenings come out that a lot of patients are having moderate or severe depression, are the proper SSRIs or other antidepressants being prescribed for those patients and having their mental health addressed prior to starting long-term chronic pain medications. And from there, they could help make recommendations for treating mental health and then also they can look and see what medications are being prescribed for their chronic pain, and correlate those with a SOAP assessment tool or other assessment tools that are screenings for narcotic abuse, and seeing if patients are getting the best recommended evidence-based care for chronic pain. It was a great project, very applicable for the clinic. The clinic was very excited to have new EMR tools put into place. They knew that way they'd be able to do more consistent care. They'd be able to do better follow-ups, be able to see from previous visits how patients are doing with their scores in the past, and see how they're doing at the visit where they're sitting right in front of them, and be able to do quick screening assessments. They were excited about the guidelines in the first place. They were just so busy they weren't able to put them into place. So having something that's right in front of them that they're able to use day to day was something that they were really excited about. So I think to continue the project and continue to make changes in their chronic pain and help them out with that would be something that the clinic is very much looking forward to do. And they want to expand that program so it really helps their population, which does have a lot of chronic pain in the population there in Jackson, Mississippi. So it was a wonderful experience, and I've had the opportunity to share it with a lot of classmates in my program, and look forward to taking what I learned and applying it to my new job. Thank you very much.
Hello, my name is Christopher Hillhouse. I'm a second-year medical student at the University of South Florida. I was placed at the Orange Blossom Family Health Center in Orlando, Florida, and my project was determining the response time of secondary care physicians when sending back referral reports. So basically, it was my goal to figure out how long it would take a secondary care physician, whether it be a cardiologist or a nephrologist or any specialist, to send back the report to the primary care physician at the Orange Blossom Family Health Center, which mainly comprised family med doctors. The methods that I used was to use a combined report for the referral system with the electronic health record system that was kept at the health center. My key findings were that I couldn't make a conclusion on the referral speed due to the lack of standardization and labeling of the EHR system at the center. Also, there was a lack of referral tracking, so everything that was done, all the data that I gathered wasn't cohesive. It wasn't a comprehensive referral tracking system. To track a patient, you would have to go into each chart individually. There was no one place to go get the information. And also, communication between all the parties in the referral process also hindered my ability to make a clear-cut conclusion on where the gap is and the break is when it comes to returning referral reports in a timely manner. The numbers that I received were that 271 patients had uncompleted referrals. Now, this doesn't mean that the secondary care physician didn't return it or that it was lost by the primary care or anything like of that nature, because there's no definitive conclusion that can be made. It's a number of things that are why that there are so many uncompleted referrals, which 271 was 73%. Only 20% were completed referrals that I had documentation that were received by the primary care health center. I also found that an increased percentage of the uninsured population had their referrals completed than the insured population. That normally would be significant because the uninsured population has a different referral system than the insured population. Uninsured population has to go through the county, whereas insured doesn't. But once again, due to the fact of the multiple factors limiting the documentation, there can't be any definitive determination on which system is better or not. My recommendation to the center was to use the data sheet to make a more comprehensive referral list and to also standardize the incoming documentation process. So to have every single physician assistant write in the same way for all incoming documentation. So if a cardiologist is sending up a follow-up report, it will say cardiology follow-up report for everybody. Everybody would write that. Currently at the center, people write it in different ways. Some people will say notes, and that's it. Some people will say cardio. Some people will say referral. So that limits the report process, and it hinders the ability to get an accurate look at what exactly is going on. So that was my project. Thank you.
Hi everyone, my name is Joey Krakowiak. I'm a second-year medical student at the Medical College of Georgia, and I was placed in Nashville, Tennessee at the Matthew Walker Comprehensive Health Center. My project focused on improving the rate of colon cancer screening at Matthew Walker with specific focus on fecal occult blood tests. So essentially what I did was I interviewed patients and providers at the clinic to identify barriers to completing FOBTs, both on the physician and the patient side. I identified three main barriers, the first being that patients were either not bringing back the fecal occult blood tests or they weren't completing them correctly. I found that the physicians were giving the patients verbal instructions on how to complete the FOBTs, and the patient would often forget those instructions, or once they got home, or they would forget about the test altogether before their next appointment. And so I thought one intervention I could try was to develop a set of written instructions for the patient that the doctor could give the patient, they could go over with the patient. The patient will have a reference when they are home collecting their stool samples and performing the test, that they'll have a reference to go to remember how to complete the test correctly. I put these instructions in with the test kit so that it's easy for the doctors to hand them out to the patient. The second barrier I found was that the physicians didn't always remember to recommend the colon cancer screenings to the patients when they were appropriate. So I created some physician reminder cards that I placed on their computer screens to remind physicians to recommend these FOBTs to patients when appropriate. The third barrier I found was that in my patient interviews, most patients did not know what the recommendations were for colon cancer screening and what their options were. So I created some educational flyers that I spread around the waiting room and the restrooms just to raise awareness about colon cancer screening and what their options were, and if they were over 50 to ask their doctor about their options. So overall, I'm planning to measure the effectiveness of these interventions by comparing last year's colon cancer screening rate to this year's colon cancer screening rate. The clinic only reports the screening rates annually, so I was unable to get a shorter time span for the time that I was there. But obviously the clinic likes the instructions sheets, and they're continuing to implement this throughout the year. So I'm definitely anticipating those results to see what this year's screening rate will be. Now, in the meantime, I was able to test my instructions with patients. I sampled randomly 10 patients at the clinic, both English and Spanish speaking, because I had both English and Spanish versions of the instructions. And after having them read the instructions, asked them whether the instructions were easy to understand, and also whether they thought the instructions would help them complete an FOBT. And 10 out of the 10 patients that read the instructions agreed to both of those questions. So at least I have some results or data to show that the instructions were on the appropriate reading level, and the patients thought that they would be helpful. So obviously my recommendations would be to continue use of these FOBT instructions. Obviously I'd like to see the results to see if they actually are making an impact to help patients complete the FOBTs correctly and bring them back on time. Also, there are many other avenues that I wasn't able to pursue during this project, during my time at the clinic. Other obstacles that I didn't focus on, other ways that you could go about creating an intervention toward these obstacles that were not done in this project. So those are future directions that I recommended to the clinic and to possibly the next person that was working at the site next year. Overall, I felt like this program was very helpful for me in developing my vision for how I want to deliver care once I get out of medical school and residency. So I'm very grateful for the experience, and I'm very thankful that I was able to learn from so many great leaders in Nashville. Thanks.
Hi, my name is Jennifer, and I'm a fourth year medical student at the University of Minnesota. I was working in LA with the Ultimed Medical Group, and my project focused on studying the effects and efficacy of interdisciplinary team meetings on hospital readmission rates, follow-up rates, and provider satisfaction. We looked at the implementation of interdisciplinary team meetings, which had been done over the previous about 6 to 7 months, on really 6 metrics, 5 of which were quantitative, and they included ER visits, readmission rates, follow-up rates at 5 and 10 days, admits per 1,000, and home health service episodes, as well as one qualitative measure, which was provider satisfaction through a survey that we had sent out to our providers. Overall, our findings in terms of quantitative metrics, we found that readmission rates had decreased, but it was not statistically significant because of our small sample size, since we had only at that point implemented the IDT meetings in 2 clinics, and we're in the process of expanding the IDT meetings. But we did find that if we were to expand the IDT meetings and continue to find the results that we had been finding over the previous 6 months, that the results would be favorable and most likely statistically significant. Our second portion of the project focused on a qualitative measure, which looked at provider satisfaction, and we looked at really did the IDT meetings improve coordination of care, and we found that they had. 10 out of 10 of our providers actually agreed that the IDT meetings should continue, and we did find that was significant. And that kind of leads me to my recommendations, which were that the IDT meetings should continue since all the providers found them very helpful. And I focused on 3 areas outside of the project, really identifying high-risk patients, which most clinics were already doing, but making sure that they were referred to IDT meetings for evaluation. And lastly, and probably the most interesting thing, was that we had found that readmission rates or follow-up rates after hospital admissions were very low, and that we needed to determine obstacles to improving timely follow-up, which probably would make a bigger impact on our hospital readmission rates. Overall, I really enjoyed working on this project, both the clinical and research aspect of my experience at AltaMed in Los Angeles. And I learned that it takes quite a bit of resources to coordinate care for socioeconomically disadvantaged populations because of the complex social factors, but that there's a lot that can be done through innovative processes, and AltaMed was really at the forefront of this movement within federally qualified health centers, and I'm really excited for what they're doing. Lastly, I couldn't have done this without the help of my mentors and advisors, Dr. Hockman and Dr. Vega. So thank you to everybody who made this experience possible.
Hello, my name is Juliana Macri, and I'm a second-year medical student at Johns Hopkins University School of Medicine. My GE, NMF, PCLP site placement for the summer was at Franklin Primary Health Center in Mobile, Alabama. And there I worked on a project related to improving referral tracking processes in the transition to EHR. So Franklin Health Center had been using a paper system for many years and had a referral tracking process that was based on using a paper system. And they had switched to EHRs but not yet transitioned the referral tracking over to the EHR. So I was looking at problems they were having maintaining those records and making sure that they were doing the tracking that needed to be done for care coordination of their many patients. So the objective of my research was to identify problems with the current paper-based referral tracking process employed at Franklin and to recommend strategies for systems that would improve tracking and facilitate more effective and efficient coordination of patient care using the EHR system. So I reviewed about 100 records of MLK adult medicine patients whose primary care physicians had requested referrals, and I identified when these referrals were not followed through to completion or completed in a timely manner. I also used qualitative methods to understand the current processes and a literature review to identify best practices and areas for improvement. What I found is that there was really no consistency or process that guaranteed timely completion of referral tracking, and that meant that a high proportion of the referrals were never followed up on. I found in my research that only 25% of total referrals made even made it into the paper-based tracking system. So there were 75% of referrals that were made in the EHR but were never even tracked in the first place. Of the referrals with follow-up, no-show rates for appointments were very high, about almost 50%. And there were large delays in the referrals that were tracked. So patient care coordination suffered as a result, and the staff were very frustrated by the cumbersome processes. My recommendations are based on the next-gen system that Franklin has implemented, and I think that that system may allow for more efficient and effective processes. Reassigning staff to care coordination tasks may also be essential to improving referral tracking workflow. And I found examples of other clinics and recommendations by professional organizations that provide useful models for improvement using the next-gen system and using referral specialists who have the specific task of tracking referrals in the primary care setting. This was a very educational experience for me. It made me realize the importance of these care coordination tasks and of having some sort of automated system in electronic form that makes it less cumbersome for staff to do these tasks and be clear on who has been followed up on and who has not. So it was a very enjoyable summer at Franklin, and I learned a lot. Thank you.
Greetings. I am very excited to participate in this colloquia through the Primary Care Leadership Program. My name is Serena Michelle Caronquo. I'm a fourth-year student at the University of Texas Health Science Center at San Antonio. I'm a 2014 MD candidate. I participated in the PCLP program in San Antonio, Texas at Centro Med Clinic. The title of my project is Transitions of Care, Investigating Patient Experience in the Transition from Inpatient Hospitalization to Outpatient Follow-Up. Now, to give a little background on this issue, I want to start by pointing out that the role of the primary care physician has changed substantially in the last 20 years. Traditionally, primary care doctors admitted their own patients to the hospital and would then follow up with them in an outpatient setting. Nowadays, the role of the primary care doctor comes with a choice to focus on practicing medicine in the outpatient setting as a general practitioner or in an inpatient setting as a hospitalist. Now, this new delegation of responsibilities certainly has many advantages. However, the disadvantage of this change is that changes in providers over the course of a patient's illness leads to a discontinuity of care that can have a major effect on the health of the patient. From a personal standpoint, this topic is important to me because I plan on pursuing a career as a hospitalist. I really wanted to know how to improve communication between my outpatient colleagues as patients leave the hospital, and most importantly, I wanted to know the impact that these transitions of care have on our patients. Now, to move on to the objective of my project, I wanted to identify problems in the transition from inpatient to outpatient management and also to investigate the impact of demographic differences in this transition. For methods, patients at Centro Med who were recently discharged from the hospital were given a 15-question survey to assess the quality of their transition. I used a survey called the CTM15, Care Transition Measure 15, which was a 15-question survey that addressed various issues such as discharge planning and patient understanding of medications adjustments as they prepare to leave the hospital. Each of the questions in the survey had a 4-point response scale, and items were calculated for each patient and converted with the linear transformation to a 0 to 100 scale, with the lowest possible score being 0 and the highest possible score being 100. The higher the score, the better the quality of the care transition. Additionally, I kept demographic information on the participants in the study so that I could compare outcomes based on this factor. For the results and key findings, the average CTM score among participants was 66.5. There was no statistically significant difference in CTM scores for non-English speaking patients. There was no statistically significant difference in CTM scores based on age. There was a disproportionate number of men who participated in the survey, but on average, men were more likely to have higher CTM scores than women. Some of the limitations of this study This study was severely limited. The power of this study was severely limited by the sample size, which was only 6. Because of this limitation, I believe that the results of my study severely underestimate the problems that patients face as they leave the hospital. As for my recommendations, from my own observation in the clinical setting, I believe that this issue of transitions of care continues to be a problem. I think that the use of the CTM-15 or a similar scoring tool could be given out as a handout to patients before discharge and then used in an inpatient setting to help identify patients at risk for rehospitalization. Low scores on the CTM-15-like tool could prompt a provider to use extra resources to ensure that a patient understands the important aspects of their hospital course, medication changes, and follow-up plan. In conclusion, I just wanted to say that when presented with research, I think it's important to always ask ourselves, why should we care? For this topic, it's simple. Delays and absence of appropriate communication between providers have negatively impacted patient care. A 2007 review of the Journal of Hospital Medicine states that nearly half of patients experience a medical error at the time of discharge, and that approximately 19 to 23% of patients experience a bad outcome as a result of an error. So I just want to close by saying that it is important as we move forward for each of us to take personal responsibility in our roles in the transition of patients as they leave the hospital. As resident physicians, we may not always have time to communicate discharge planning face-to-face with our patients. And for the physicians, I think it's really important to write good notes and provide good discharge summaries for our outpatient colleagues. For nurses, at least in the hospital that I work in, nurses play a critical role in explaining discharge instructions to patients. So I just urge nurses to take time when they're explaining, and if they don't understand the instructions themselves, to please ask for clarification. And lastly, to the patient, because at one point or another we'll all be one, I urge you to take ownership of your health and don't rest unless you understand everything that's pertinent. In closing, I just want to say that I truly enjoyed my time as a PCLP scholar and my time at Central Med. I got to spend time with a diverse group of leaders who are incredibly intelligent people who helped me see a much bigger picture of this field that I'm about to dedicate my life to. I'm a richer person for this experience, and I have learned things that I will carry with me throughout my career. I only hope that I continue to have opportunities to grow and become a leader in this incredible field. Thank you so much for your time.
Hello, fellow scholars, primary care leadership program advisors and staff, members of National Medical Fellowships, the GE Foundation, and everyone else viewing this presentation. My name is Rachel Rafferty, and I'm a second-year medical student in the MD program at Drexel University College of Medicine in Philadelphia, Pennsylvania. And this summer, as part of the GE National Medical Fellowships Primary Care Leadership Program, it was my pleasure to work at United Neighborhood Health Services, UNHS, in Nashville, Tennessee. And today I'm going to walk you all through a summary of my independent project, which was improving the utilization and sustainability of a mobile health clinic in Tennessee. The objective of this project was to develop a sustainable model to improve the efficacy of a preventative care mobile health screening unit, or MHSU, utilized by United Neighborhood Health Services, a federally qualified health center in Nashville, Tennessee. You may be asking yourself, what is a mobile health screening unit? Well, essentially what an MHSU is it's a doctor's office on wheels. It contains medical equipment, and its purpose is to go out into the community along with a healthcare professional and provide free healthcare screens for hypertension, diabetes, and other chronic conditions to anyone who wants one, with an eye to getting screened individuals with abnormal results into medical homes for intervention. And you may be asking, well, why would this project need improvement? I'll try to outline that a little bit as I go along. Essentially, I discovered when I came onto the site that this mobile unit was suffering from having some problems that were limiting its efficacy and penetration into the community, and I sought to combat that through this project. My methods for doing this were that with my site I developed 3 specific goals and set them to determine successful improvement of the MHSU function, and I made key changes to the old screening model and developed new tools to meet each of these goals. Our first goal was to streamline the collection of data for both the patient and the clinic. At the time that I came on site, the mobile health screening unit was not collecting any data for itself to measure its effectiveness in the community or to be able to report about that. And also the patients that were being screened were not obtaining any results about their glucose levels, their hypertension, anything that they were being screened for. And so in order to combat this problem and get some data flowing in both directions, I developed patient screening forms for the clinic that the patients filled out. I developed results forms for the patient to keep that the provider would fill out. And I developed statistical Excel databases in order for the clinic to keep track anonymously of the people that it screened. And these were all implemented while I was on project. Goal number 2 for improvement was to increase the number of screening events. Because UNHS staff were being used to staff the MHSU when I came on project, it could only run on weekends when staff weren't needed in clinics, which meant that it performed very few screening events per month. It was being staffed with a paid healthcare provider, which made it very expensive to run, and they could only afford to pay one person at a time, so patients could only be screened one at a time, which meant that the events were very low yield in terms of trying to get into the community. In order to combat this problem, I gave deliberate focus to scheduling weekday events at high visibility venues like community centers in particular, where there would be a high traffic flow and a great potential of patients. With available weekday space for us to have the events and running those events by non-clinic individuals, for example, students, as I'll mention later, with weekday availability. And our third and final measurable goal was to decrease the cost to UNHS. As I mentioned before, the mobile unit was very expensive to run, and our key goal to cut down on that cost was to, in place of the paid clinic provider, to recruit, train, and use healthcare students to perform those screens. And through a series of tools that I developed, we were able to recruit, train, and use healthcare students to perform our screens while I was on project. The key findings of the project were that 8 events and 102 patient screens were performed over a 3-week period. And when we contrasted all of the data that we collected to the old screening model, we found that our implemented changes did show increases in the total number of events conducted. We saw a 200% increase in events. We saw an increase in the total number of patients screened. We increased that by 30% over the old model. And we saw reductions in both overall screening event costs, a reduction of 33% per event, and cost per patient screened, 48% less to screen a patient to UNHS with our new model. So based on those key findings, we determined that we were able to successfully meet all 3 of the measurable goals for the project. Recommendations for this mobile unit going forward after working on it, I recommend that the UNHS should designate a staff member solely for driving the mobile health screening unit so that whenever an event is scheduled, the unit will be able to be on site. Also, I would recommend that standardized application forms for screening sites outlining the services that they want us to provide should be developed. At times there were confusion about that, and that was a little difficult for the community, but a simple application form should be able to clear up that problem in the future. All in all, I thoroughly enjoyed this project and I'm very proud of it. The actual patient data I compiled, which is available in my final paper and presentation, is very compelling, and it makes a strong case all on its own for the effectiveness of the Mobile Health Screening Unit Intervention Program. Preventative health is a passion of mine, and I've participated in similar health screening projects here in Philadelphia for hypertension and diabetes for more than 2 years now, and so I was excited to be able to use my previous work to make a real difference in the clinic's outreach and to be able to spend my summer improving the health of the Nashville community through this project. I'd like to thank the GE Foundation, the National Medical Fellowships, the Primary Care Leadership Program. Thank you so much for this opportunity. I'm really grateful. Thank you all so much.
Hello everyone, my name is Kenji Taylor. I'm a 4th-year medical student at the University of Pennsylvania. I was placed in West Memphis, Arkansas with the East Arkansas Family Health Center, or EAFHC. And I worked with the COO, Ms. Cherry Whitehead Thompson, to develop and implement an online qualitative and quantitative employee satisfaction survey, which took place in July until mid-August. So EAFHC has just looked at patient satisfaction, how satisfied are patients. And research has shown that in addition to patient satisfaction, employee satisfaction really drives how happy a customer is with that particular survey. So EAFHC wanted to implement an employee satisfaction survey that could be repeatable and used every year, done online, and they could also be scaled across not just their one site in West Memphis, but their four other rural sites in East Arkansas. So in order to do that, we created an online survey that used a Likert scale, so a scale from 1 to 9 that said I either strongly disagree with this particular statement or strongly agree with this particular statement. And we also used 3 text questions. And the questions themselves dealt with things in 4 areas. The first was upper management, CEO, CFO, and COO, which is general question in management at the upper level. The next set of questions, the 4 questions, dealt with the satisfaction of the supervisors, how good is the communication, do they get kind of constructive feedback and criticism, do they feel like their opinion is being taken into account. The third section dealt with finances and communication. And so, do they think money is being spent appropriately? Do they think good communication, they execute communication throughout the country? And then the last one was just overall satisfaction and loyalty with viewers of the EAFHC. And that was a question of 4 questions as well. So we developed this online survey tool using Google Docs, and we got emails from employees across 5 different sites. It took a couple weeks because not all the employees had company email. We deployed the survey for 1 week, and then we collected and analyzed the results over the course of the last couple of weeks of my time at East Arkansas Health Center. So some of the things that we found from the employees were, some of the strengths. So we saw that overall, people were very satisfied with their job and had confidence in senior management. Pretty much across the board, across the CEO, CFO, and COO. They strongly agreed with the comment that they trusted the CEO to make particular decisions. However, in terms of areas of improvement, at the supervisor level, we started to see a little bit more breakdown and variability in responding to the comments about supervisors. So certainly areas of improvement regarding management at the supervisor level. But communication throughout the organization was another challenge and area of improvement for the organization. As several people commented not only in the quantitative feedback, but also the qualitative feedback, that they felt that communication between employees could be better, communication to patients could also be better, and that even from some of the sites outside of the central site of West Memphis, they felt at times that they weren't always included in all the discussions as well. And there were also some, another problem that we identified was around low-level email use and technical training. As I mentioned, not all of the employees had access to a company email, so we ended up having to use personal email for work-related purposes, which posed some challenges. And not all the staff are really familiar with using the internet to answer these questions. So based off of the survey that was carried out, some recommendations I had was to continue to survey the employees either annually or semi-annually, because now that we have a baseline, we can get a sense for whether or not we're doing a better job with communication and with management at the supervisor level. I think because there was an issue with supervisor management and leadership, I suggested providing further training for supervisors, along with transparent policies for managing certain disciplinary actions that the employees talked about in their surveys. And we also talked about considering reevaluating particular supervisors for the positions to ensure that, quote, the right people are for the right job. This was a quote from one of the employees in the survey. So overall, I'd like to thank GE, NMS, EAFHC, and all the folks that I worked with over the last 6 weeks there. It was certainly a great learning experience to understand the SQHC in rural clinics in rural areas and a part of the country I've never been before. It was a great way to work with management to understand some of the issues that primary care providers face in the environment. I hope that the employee satisfaction survey will continue to help the organization improve, and really thank them for putting in the effort to spend some time with us. All right, thank you.
We've just heard about these 7 projects that the students carried out this summer. Several of them had to do with referrals and coordinating referrals and completing referrals from a primary care clinic. Several had to do with transition of care from an inpatient to outpatient setting and avoiding readmissions. Several had to do with appropriate use of services, increasing cancer screening and decreasing opiate use, and one had to do with clinic employee satisfaction. There's some major themes that these projects brought out, including the role of individual responsibility and individual adherence versus systems that nudge toward compliance. And that has to do with both patients and providers. The second theme has to do with lack of coordination and communication that occurs between hospitals and outpatient settings and how that can be improved. And the third theme is systems and organization of information systems and how important they are to achieving the aims of a medical home. I'd like now to pose some questions for the scholars to consider. And these are questions that come from their projects and which their projects raise. The first, what are some of the practical issues that need to be considered when they're introducing a protocol into a clinical setting? A protocol, you can make protocols easy enough, but getting them to be followed is another matter. The second is, how can recalls and reminders assist in increasing patient and provider adherence to prevention recommendations? We might as well be using effectively our information systems to help increase adherence to prevention recommendations. The third, what checks and balances can be put into place to monitor for overuse of narcotics? Narcotic abuse and overuse and overdose, including deaths from overdose, is an increasing national problem, so this particular question has high pertinence for today's problems. And then the fourth, what can a medical home do to increase its participation in and knowledge about hospital care provided to its patients? This is another very pertinent question and contemporary to today's healthcare system, in that in the hospital, the physicians who take care of the patients are frequently not the physicians who take care of the patients in the outpatient setting. And communication between these two settings is crucial to maintain continuity of care and to avoid adverse